Bulimia Nervosa by Stephanny Suministrado for Nursing 106, Mental Health Nursing. Bulimia nervosa is the repeated episodes of binge eating followed by compensatory behaviors, like self-induced vomiting, misuse of laxatives, diuretics or other medications, fasting, and excessive exercise. It is characterized by significant disturbance in the perception of body shape and weight. Essential features are binge eating followed by feelings of guilt, humiliation, and self-deprecation, associated with depression. Usually begins in adolescence or early adulthood and can occur simultaneously with anorexia nervosa. Patients are typically within the normal weight range, but some may be slightly below or above ideal body weight. Contributing factors to patients with bulimia nervosa. As to biological factors, there is a strong genetic link but no single causative gene discovered to date. There is evidence that certain gene abnormalities may predispose to symptoms of eating disorders and risk for developing full-blown eating disorder. Neurobiological theories identify an association among eating disorders, depression, and neuroendocrine abnormalities. As to psychological factors, they explore issues of control related to eating disorder. Cognitive behavioral theorists suggest they are based on learned behavior that has positive reinforcement despite the fact that health is at risk. For example, "Wow, you look great," to a mildly overweight 14-year-old who has a flu. Family theorists says that eating disorders are a problem to the whole family. Often, symptoms in the child serve to take attention away from distressed marriage. As to environmental factors, social-cultural models look at our present societal ideal of being thin. Culture influences the development of self-concept and satisfaction with body size. How is the brain relevant to bulimia nervosa? There are areas of the brain affected, such as the frontal, cingulated, temporal, or parietal regions of the brain. One or combination of these brain regions has differences in controls that are affected in acutely ill and recovered patients based on studies. The neurotransmitter involved is serotonin. Research demonstrates that altered brain serotonin function contributes to dysregulation of appetite, mood, and impulse control in the eating disorder. Serotonin pathways of the brain modulates personality traits. Tryptophan, an amino acid essential to serotonin synthesis, available only through diet. Temporary drops in dietary tryptophan may actually relieve symptoms of anxiety and dysphoria, and provide a reward for caloric restriction. This cycle of temporary relief followed by more dysphoria sets up a positive feedback loop that reinforces the disordered eating behavior. Here is a sample of a patient profile. We will further discuss this in the next slide. Anna Sue is a 16-year-old female Asian senior high student. Her height is 5 feet 4 inches, and her weight is 55 kilograms. She is always top in her class and is very beautiful. She is an only child, living with her parents in Saskatoon. Her father is a renowned lawyer, while her mother is a businesswoman. At home, she is always reminded to maintain her spot as top one and maintain a good body image for the family. She has a history of mild anxiety and anorexia nervosa when she was 11 years old due to her parents' constant pressure. She has a chronic intake of diet pills and laxatives for half a year. She is admitted in Royal University Hospital with a case of bulimia nervosa. She was reported by her school teacher where she was inducing vomiting in the bathroom. When she was admitted, she perceives herself as fat. She verbalized being pressured by her parents for her grades and image since she was young. She has taken diet pills and laxatives for about 6 months. Her weight is within ideal weight for her body. However, she has 5 teeth with dental erosion and caries. There are calluses in her right hand. She has poor skin turgor and pale skin, and her potassium and calcium was low. After 2 weeks in the hospital, she is now nearing discharge. Her laboratory tests are not optimal. In the nursing process, there is therapeutic communication between Anna and the nurse. There are 2 samples here in the slide. In the first example, Anna is afraid that she will relapse and try to vomit after eating again. The nurse says, "Perhaps by working together we can come up with some ideas suited for you that might help suppress the urge to binge and purge." This technique is suggesting collaboration. It emphasizes working with the patient, not doing things for the patient. It also encourages the view that change is possible through collaboration. In the second example, Anna is admitting that she did this to herself, and she is embarrassed. She has many thoughts in mind, and she has many questions before she gets discharged. The nurse states, "I'll stay here and sit with you for a while. And where would you like to begin?" The first technique is offering self. It offers presence, interest, and a desire to understand. In the second statement, the technique is giving broad openings. It clarifies that the lead is to be taken by the patient. However, the nurse discourages pleasantries and small talk. In the nursing care plan for bulimia nervosa, I specified 2 priority nursing diagnoses. The first is imbalanced nutrition less than body requirements related to self-induced vomiting and chronic laxative use, possibly evidenced by poor skin turgor and pallor. The treatment goal here is that the client will establish a dietary pattern with caloric intake to maintain appropriate weight. Nursing interventions are supervising the patient during meal times and for a specified period after meals, which is an hour. This prevents vomiting during or after eating. Also outlining the risk of laxative abuse for the patient. Bulimic patients may include abuse of laxatives like Anna. Treatment outcome is at the end of her hospitalization, Anna is following a consistent dietary pattern with caloric intake and is aware of the risk and complications of laxatives abuse. The second priority nursing diagnosis, ineffective coping skills related to lack of family support and peer pressure, possibly evidenced by binging and purging, tooth decay, abuse of laxatives, and distortion of own body image. The goal here is that the client will identify the relationship of signs and symptoms like weight and tooth decay to behaviors of not eating or binging purging and will assume responsibility for her own learning. Nursing interventions are determining the level of knowledge and readiness to learn. Learning is easier when it begins where the learner is. Discussing the consequences of her behavior. Gastric rupture may follow binge eating and vomiting. Encouraging the use of relaxation and other stress management techniques like visualization, guided imagery, biofeedback. New ways of coping with feelings of anxiety and fear help patients manage these feelings in more effective ways. It also assists in giving up maladaptive behaviors of binge and purging. The outcome here is that At the end of her hospitalization, Anna understands the relationship of her weight and tooth decay to binge eating and purging, and its complications. She has started other coping techniques to relieve anxiety. Patients with bulimia nervosa like Anna is usually given fluoxetine hydrochloride or Prozac. It is classified under antidepressant. It is a selective serotonin reuptake inhibitor. Its treatment may help prevent relapse of bulimia nervosa. Limited research suggests that the SSRI and tricyclic antidepressants help reduce binge eating and vomiting over short terms. Therapeutic effects are antidepressant and decreased behaviors associated with panic disorder and bulimia. Prozac is well absorbed after oral administration. It is distributed and crosses the blood-brain barrier. It is mostly metabolized by the liver and excreted by the kidneys by 7 to 12%. Its half-life would be 1 to 3 days and up to 5 to 7 days. Its usual route is per RM, with the onset of 1 to 4 weeks after intake, with a duration of 2 weeks, where peak is unknown. The dosage is 20 to 60 milligrams per day. Adolescents and higher weight children like Anna is usually dosed at 10 milligrams per day and may be increased after 2 weeks to 20 milligrams per day and may increase additionally after several more weeks. It is contraindicated for patients with hypersensitivity to fluoxetine and patients with concurrent use of monoamine oxidase inhibitors. Adverse reaction of fluoxetine are seizures, anxiety, drowsiness, headache, insomnia, nervousness, diarrhea, sexual dysfunction, excessive sweating, pruritus, and tremors. There are many nursing implications for fluoxetine. Samples here are monitoring mood changes, assessing suicidal tendencies and sexual side effects, like decreased libido, assessing frequency of binge eating and vomiting, monitoring appetite and nutritional intake, and weighing weekly, assessing for sensitivity reaction, instruct to take fluoxetine as directed and no voluntary double doses or discontinuing. Instruct to avoid alcohol or other antidepressants and consult before taking natural or herbal products during therapy, like St. John's wort. Caution to change position slowly to decrease dizziness. Instructing good oral hygiene and frequent mouth rinses to prevent drying of mouth. Advice to notify healthcare professional if adverse reactions persists, and emphasize on importance of follow-up exams to monitor progress. Encourage also participation in psychotherapy to improve coping skills. There are a few support services for Anna in Saskatoon. The Canadian Mental Health Association in Saskatoon, which is open Monday to Thursday, 8 to 4:30, except statutory holidays. There are also 24/7 crisis support services like 911 for emergencies, 811 Helpline Saskatchewan for any mental health or any illnesses or COVID-19 response, and the Saskatoon Crisis Intervention Service with a mobile of 306-933-6200. These three are all 24/7 hotlines, which is available for Anna anytime. Here are the different sources that was used in this presentation. And this ends my presentation for bulimia nervosa.